Good afternoon. My name is Dr. Renelle Miles, and I want to welcome you to the NIH Office of Disease Prevention's Medicine Mind the Gap seminar series. This seminar series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to promote the use of the best available methods in prevention research and to support the development of better methods. Before we begin, I have some housekeeping items. To participate by Twitter, follow us at NIHPrevents and submit questions using the hashtag NIHMTG. You may also email questions to prevention@mail.nih.gov. There is also a link to a feedback form at the bottom of the videocast page where you can submit questions during the talk. At the conclusion of today's talk, we will open the floor to questions that have been submitted via email and Twitter. Lastly, we would appreciate your feedback about today's seminar. Following today's talk, please visit the ODP website at prevention.nih.gov/mind-the-gap and click the link to the seminar evaluation under the resources section. Your insights will help us to continue to improve this seminar series. At this time, I'd like to turn things over to Dr. Rachel Ballard, Director of Prevention Research Coordination here in the Office of Disease Prevention.
Hello, everyone. Thank you, Renelle. Today is the final part of a three-part Mind the Gap series on screening and disease prevention. Dr. David Ransohoff presented in September on making guidelines for colorectal cancer screening, and Dr. David Grossman presented last month on guidelines for screening in children. And today, Dr. Ruth Etzioni will present on defining and measuring overdiagnosis in cancer screening. Dr. Etzioni is an internationally known biostatistician and full member of the Division of Public Health Sciences at the Fred Hutch Cancer Research Center. Her program has focused for many years on the development of innovative statistical and computer models to learn about the latent process of cancer progression from observed disease data on disease incidence and mortality. And that knowledge is then applied to fill evidence gaps that arise when policies are developed for cancer detection and management. A major component of her research addresses the development and evaluation of methods for estimation of overdiagnosis, which is in many ways an unobservable outcome of cancer screening. Dr. Etzioni was the first to quantify the frequency of overdiagnosis associated with prostate cancer screening in the U.S. and has applied that same methodology to examine questions related to overdiagnosis in breast cancer. Her models have been used to identify preferred policies for prostate cancer screening, to project long-term comparative outcomes of active surveillance, to determine how to tailor screening policies according to disease risk, an increasing focus of today's work in many areas, and to reconcile apparently conflicting trials of prostate cancer screening and treatment. She's a member of 3 national prostate cancer screening panels and has co-authored the recently updated American Cancer Society's recommendation on breast cancer screening. She leads the Cancer Intervention and Surveillance Modeling Network's Prostate Cancer Group and is a fellow of the American Statistical Association. It's my pleasure to welcome Dr. Ruth Etzioni. And Ruth, we turn that session over to you now.
Well, good morning, good afternoon, everyone, and thank you so much for joining. I'm delighted to be able to spend some time talking about a topic that we have thought a lot about over the last decade or more. It'll become clear during my presentation why you're looking at a picture of an iceberg and a picture of a wave. I think it's clear that overdiagnosis has now very much become part of public information about cancer screening. And here I'm showing an article from the Wall Street Journal. And it's been the gathering information about overdiagnosis has been very influential in how we think about cancer screening and, in fact, sowed a great deal of concern, I think, about cancer screening interventions. The title of this article, It's Time to Rethink Early Cancer Detection with Statistics about Overdiagnosis in prostate, breast, and other cancers under a heading fatal retraction. These numbers are then very much driving policy recommendations. And here's an article from last year from Health Affairs about expenditures as a consequence of overdiagnosis, with just one of the many press pieces, mammography's a $4 billion problem. So what are we going to do today? The first thing as a statistician that I think about is are we getting the numbers right? Before we panic and before we change and move policies, we want to be sure that we're doing so on a reliable basis of information. And so today's presentation is really about those numbers regarding overdiagnosis. How do we get the numbers right? And before we get there, we'll first talk about overdiagnosis, what we mean, the concept and implications, and we'll talk about then two ways that people try to approximate the magnitude of the problem. And I'll refer to them as an excess incidence approach and a modeling approach. And in both cases, we'll look carefully at how these approaches are used and how they can be validly applied. And in each case, I'll then present some examples of published studies. And the goal is to help all of you as consumers and readers and users of overdiagnosis studies to be able to read the literature, to look at different studies, and really think about about whether the conditions for valid estimation have been satisfied and what those and help you to identify what those conditions are. So ultimately, by the end of this presentation, I'm hoping that you'll have a sense of the complexity of the problem of estimating overdiagnosis, the importance of getting the numbers right, and how to open up a newspaper, read some numbers about overdiagnosis, and think about whether you can those numbers can be trusted. All right, let's talk about overdiagnosis, the concept of overdiagnosis. And I'll talk about it particularly, of course, in relation to cancer screening. There are different definitions of overdiagnosis, but the one that is most commonly used and the one that we will use today is the following. An overdiagnosed cancer is a cancer that's detected by a screening test, but would not have been detected in the absence of screening. So here we have a schematic of a cancer that has a time of onset, a time of clinical diagnosis without screening, and I've also shown the point at which non-cancer death would have occurred. So in this case, death from other causes, non-cancer death, would have occurred after the time of clinical presentation of the tumor. Screen detection advances the date of tumor diagnosis, and the interval by which the diagnosis is advanced is called the lead time. And because this screen-detected cancer would have been detected in the absence of screening within the lifetime of the patient, it is not overdiagnosed. However, in the case where non-cancer death would have occurred before the time that the tumor would have been diagnosed without screening, we have a situation where screening has identified a cancer, and in the absence of screening, that individual would not have known about that cancer within their lifetimes. It would not have been and would not have presented clinically. In that sense, that diagnosis is an excess diagnosis. It's a diagnosis that would not have occurred in the absence of screening. And that is what we mean by overdiagnosis. And I'm just going to toggle back to the previous slide so you can see what I had to do to change the timeline, to change from non-overdiagnosed to overdiagnosed. You can see that I brought in the non-cancer death and I extended the lead time. So we can learn some key principles about overdiagnosis from these figures. So the first one is that it is unobserved. Once an individual is screen detected, typically treated, we do not know when that point of clinical diagnosis would have occurred. So it depends on this unobserved lead time, and it also depends on the risk of other-cause death. And that's why we can think of overdiagnosis as an iceberg. First of all, we're finding cancers that are below the surface that would not have presented. They're latent cancers, but they're being brought up to the surface by screening. And in addition, overdiagnosis depends on something that's unobserved, the lead time. It is below the surface. Overdiagnosis occurs when the lead time is longer than time to other-cause death, as I showed you in the figures. But what does that mean? It means that it's more likely when disease is slow-growing or non-progressive, so it's a long time from the time of screen diagnosis until clinical detection, or it is a short time to other-cause death if patients are older or sicker. So the lead time is longer, or there's a shorter time to non-cancer death, there is a greater likelihood of overdiagnosis. Now, the thing about overdiagnosis and screening in general is that even though it rests on something unobservable, it has observable consequences. Screening has observable consequences, and these can help to inform us about overdiagnosis, about what lies beneath. So here I'm showing the pattern of disease incidence with the introduction of a screening test. And there are two panels. They have two different lead times. In the first panel, the lead time is 1 year, and the second panel, the lead time is 2 years. What happens when we introduce a new screening test? Well, in this case, I also want to mention that we have an underlying constant incidence of cancer at a level of 100 in both cases in the absence of screening. And that is the light gray shading on the figure. And screening begins, a marked point at which screening begins. And what happens when we introduce a new screening test is that we have a pattern of incidence, excesses, and deficits in the population as screening reaches forward into the future and diagnoses cancers from the future earlier. And that's what's represented by the plus signs in the figure. In each case, in the first year, 30 cases are diagnosed by screening. In the second year, 20, and the third year, 10, and following the third year, 10 cases. So those cases are diagnosed earlier, but that means that they no longer are present in the population later to be diagnosed, which causes deficits, kind of like a wave that pulls water from ahead and causes a crest. So the time, and this causes a deficit, this deficit in incidence. And the time between the incidence excess and the incidence deficit corresponds to the lead time. So if, in the first case, the lead time is 1 year, there's an excess of 30 in the first year, and then 1 year later, there's a deficit of 30. In the second, in the lower panel, there's a 2-year lead time, so there's an excess of 30 in the first year, and that deficit of 30 happens 2 years later. And you can see that those different lead times correspond or generate different patterns of incidence. But what you'll notice is that the excesses and the deficits are the same in the figure. So every excess case matches a case that would have been detected later. There is no overdiagnosis. All the early detections would have been detected later and are therefore no longer there in the population to be diagnosed. And in both of these cases, there is no overdiagnosis. But what we'll note is that there's still a bump in incidence in both cases, even if there is no overdiagnosis. So understanding overdiagnosis in these two different ways leads us to two approaches for estimation. In the first case, we recognize that the observed incidence tells us something about the lead time and therefore about overdiagnosis. And the first approach uses that observed pattern of incidence as a proxy for estimating overdiagnosis and considers the difference in incidence with and without screening as an estimate. But the second approach recognizes that difference in incidence tells us something about what lies beneath and tries to estimate the lead time to generate a projection of overdiagnosis. So the first approach is empirically based, and the second, we would say, is maybe modeling based because it uses statistical methods to learn about the underlying progression of disease. So what I would like to do now is talk about how considerations that play into generating valid estimates in each case. What's interesting is that published estimates vary widely. I'm showing here some studies from breast cancer. The shaded rows of the figure are results of excess incidence studies, and the non-shaded rows are results of modeling studies. There are other differences across the studies besides the approach. For example, there are different measures. I have a column showing the different measures of overdiagnosis, and these can also lead to differences across studies. And some of the studies include in situ cases and some don't. But generally, we can see that those excess incidence studies tend to be produce results that are considerably higher than the modeling studies. So first we'll do an in-depth look at excess incidence, and we'll look at three particular issues. The first is timing. We know that from the previous slide that there is a bump in incidence. There is excess incidence even in the absence of overdiagnosis early on when a screening test is introduced. This suggests that we need to think about the timing of estimation when we're using excess incidence. And then we need to think about the metric, the measure for estimation. And I'm going to particularly talk about measures that are cumulative, that look at cumulative measure of excess incidence, or kind of an annual measure, a point measure of excess incidence. But there are other issues related to metrics, and particularly, if I can return to the previous slide, looking at the measure, typically overdiagnosis is presented as a ratio, a fraction of cases overdiagnosed, but very often the denominator of the ratio is either not mentioned, and different denominators can give you very different results. So, for example, if you look at overdiagnoses relative to screen-detected cases or overdiagnoses relative to all cases detected, you may get very different results just by virtue of the measure that you're using. And the final thing that I'll mention and that we'll look at carefully is this question of the background incidence. So everything that I've shown you in this toy example we know that there's a constant background incidence, but it's not always obvious, particularly in population studies, what that background incidence is. So I'm going to look, in the case of excess incidence, at different types of studies. First, we'll look at clinical trials, and then we look at population studies. And within clinical trials, I'm going to partition the designs into a continued screen trial, in which screening is continuous through the duration of the trial, and stop screen trials, in which screening occurs for several years, but then both screening and control groups are not screened until the trial is analyzed. And I'm going to show you some work that we've done that developed a general model of these of how screening impacts incidence given a specified level of overdiagnosis. And the setting that we're going to look at is, again, constant preclinical incidence. So we're going to look at cancers that have onset at a constant rate. We're going to specify a maximum preclinical period of 6 years. We're going to assume constant test sensitivity and no overdiagnosis. So what this work does is it takes an underlying specification, such as the one I've just shown you, and it translates it into what you would expect annual incidence to be. And here is a continued screen trial with these specifications. And on the right panel, I'm showing you the pattern of annual incidence that you would get in such a trial. The top panel is annual incidence, and the lower panel is cumulative incidence, which is often presented in the reports of the results of such studies. So with annual incidence, the incidence in the screen group is in green, the incidence in the control group is in purple. And we see a very similar pattern to the slides that I showed you of the incidence evolving over time. Everyone begins screening in year 1, and there's an incidence bump in year 1, and control group is constant over time. And eventually, the incidence, there's no overdiagnosis in this setting, so the green curve ends up converging down to the purple curve, and at a certain point, they are equal, and we have a point in which we can estimate overdiagnosis in an unbiased fashion. However, in the cumulative setting, we see that the two curves never meet. So the cumulative excess incidence is persistently biased because it's always positive, but there's no overdiagnosis. And notice the point at which we have an unbiased estimate in the annual incidence setting. It's at year 7, which is the first year that screening started and then continued after that year, plus 6, which is the maximum preclinical period. And I'm showing you here an interface that is available for use that can generate these kinds of patterns under any setting for the underlying disease parameters on the left here, and then produces results on the right. In this particular case, we actually have produced some results in the presence of overdiagnosis and shows you the point at which you can expect unbiased results. What's the problem with cumulative excess incidence? Well, cumulative excess incidence in a continued screen trial ends up being persistently biased for overdiagnosis, and that's because we know that in a screening trial where screening continues over time, we know that screening is pulling cases forward from the future. When we cut observation off at the same time for screening and control groups, we are no longer counting those cases from the future. And so even in the absence of overdiagnosis, the cumulative cases in the screen group will always exceed the cumulative cases in the control group. And so cumulative excess incidence in a continued screen trial is persistently biased. Now, not all trials are continued screen trials. Particularly the early trials and several trials in breast cancer screening are stop-screen trials, in which screening only took place in the first few years of the trial. And in that case, here are the figures under the same specifications as the previous slide. We actually find that cumulative excess incidence does become unbiased because we're giving time for those cases beyond the screening period to be diagnosed and therefore to be counted in the excess incidence calculation. So cumulative excess incidence does eventually become biased, and unbiased, and annual excess incidence also becomes unbiased. But when does this happen? In this case, we had a period of 4 screening tests. So the point of unbiasedness happens when screening ends plus the maximum preclinical period, not when screening starts. So we can remedy the problem of cumulative excess incidence when we have a stop-screen trial. What about population studies? Well, population studies present a problem because background incidence is generally not available. We don't have a control group like in a clinical trial. But if we can estimate the background incidence, the same considerations will apply in the population setting. So first of all, the cumulative excess incidence estimate will be persistently biased, and for the annual excess incidence, it will ultimately become unbiased, but we have to wait until screening stabilizes, plus the maximum preclinical duration. And so here I'm showing you results from 3 population settings. In the first 2, we have the 6-year maximum preclinical detectable period, and in the second, in C, we have a 12-year maximum preclinical detectable period. And in the first case, we have uptake of screening from years 2 to 6, and in the second case, uptake of screening from years 2 to 4. And what we see in each case is that we have to wait until screening use stabilizes plus the maximum preclinical duration. And if we know those, we can get a sense of where we can do the calculation. Here we actually have programmed some overdiagnosis in, and the model and the interface give us the point at which our estimate has become unbiased. And here's the interface that shows you. And in all of these settings, there are minimal set of specifications to be able to generate estimates of the point at which estimation will become unbiased. But we can see that there's clearly a timing issue, and this has been identified by many investigators studying methods for overdiagnosis studies. So just to conclude this part of the talk, talking about screening, about excess incidence. So the first point that I want to make clear is that having a clinical trial does not automatically guarantee you an unbiased estimate of overdiagnosis. The design of the trial, the timing of the estimate, the measure, all of these play into the validity of the results. And we tend to think that clinical trials are the answer to everything because they give us the control group. And certainly this is valuable to have a control group, but we need so much more for validity of overdiagnosis estimates. I want to note that there's been a lot of work about methodology for excess incidence, and particularly in settings where where a restricted age range is screened, and we have not taken this into account in the interface and model that I've shown you. We're looking really at screening the entire population and have not got an age structure. But if you do have an age specific screening range, then there are other considerations to think about, which I don't have time to go into here. Okay, so what I'd like to do is I'd like to take these principles that I've shown via this model of overdiagnosis and look at published studies and see how they line up with respect to some of these principles. The first one I'll show you is the European randomized study of screening for prostate cancer. This was a multi-center study done in Europe. It was a continued screen trial. Most centers screened every 4 years. Sweden screened one center screened every 2 years. And if we look at all the estimates of overdiagnosis that were presented were cumulative excess incidence. So these are trial publications that have been updated over the years, but we can see that the estimates suggest that more than half or more of screen-detected cases are being overdiagnosed. So the denominator here is screen-detected cases, and the suggestion is that half or more of screen-detected cases are being overdiagnosed. So from what we have shown, we can infer that these numbers are likely overestimates because we have a continued screen trial in which cumulative excess incidence is being used to produce these estimates. And what's interesting about this trial is that there were 2 prostate cancer screening trials. This trial had a significant benefit of screening in contrast to the U.S. trial that did not show a significant benefit. But the enthusiasm for the results of this trial was tempered by the high frequency of overdiagnosis. Okay, so let's go to another study. This is the Canadian National Breast Screening Study. This was a stop screen trial, compared mammography plus clinical breast exam with clinical breast exam. The screening happened in the first 5 years, and in the last couple of years, a 25-year follow-up was published. And so we have now many years following the first 5 years, and so we have, it was a cumulative excess incidence estimate of overdiagnosis that was presented in a stop screen trial after a long follow-up, giving plenty of time for overdiagnosis to become unbiased. So in fact, this is a good design and a long duration to estimate overdiagnosis. But there's a difficulty with this trial, and I think in all stop screen trials, with determining what the right denominator is for the excess cases. So the table shows the excess cancers at different points of follow-up, but these are all divided by the 484 screen detections in the first 5 years. And clearly, once one is going out to year 25, there's a cumulative diagnosis that likely is not being impacted by what happened in the first 5 years of the trial. So there's a difficulty with the denominator here, and there's also a question about whether screening really stopped in both groups. And we know that it didn't because this slide shows when Canadian screening provinces actually began initiating screening programs after the trial was first reported in 1988. But the question is whether the two arms of the trial later adopted screening at similar frequencies, and whether we really can count the cumulative cases or the cases that were diagnosed after the trial was completed and compare incidence in the groups. Because, for example, if the group that had had mammography during the trial now adopted screening that was offered at a higher frequency than the group that was in the control group of the trial, then we would have a diverging cumulative excess incidence. And we have a hint of this in the younger women when we're looking at the cumulative incidence in the mammography plus breast exam arm versus the versus the control group. We can see that there was a divergence over time, making it important to recognize that if you have a stop screen trial, in principle, with long follow-up, you can get unbiased estimates of overdiagnosis, but you need to be sure that you have a stop screen trial. Let's look at a couple of population studies. All of these studies published with a certain degree of prominence, some of them a lot of press, and we can really use the principles that we've advanced to try to understand, whether we can trust the numbers. So here's a study of prostate cancer excess incidence. The figure on the left shows excess incidence in different age groups. The baseline is 1986 incidence. So in 1986, that's why we have a 0 for all the curves. And this was a cumulative excess incidence study that suggested that 1.3 men had been diagnosed with prostate cancer, had been overdiagnosed with prostate cancer from 1986 to 2005. This number widely reported based on cumulative excess incidence and assuming that background trend would have been constant at 1986 levels in the absence of screening. And the last population study that I'll show you in the U.S. is this very prominent study of breast cancer screening. On the left, we have incidence of early stage and late stage breast cancer, and it's an excess incidence estimate looking at the difference between observed incidence and background incidence, where the background incidence is the background incidence trend is imputed based on younger women under 40 who were not exposed to screening. And this particular estimate of background trend has been questioned in many responses to this publication. So going back to our principles, this is an annual excess incidence. It has a long follow-up after the dissemination of mammography in the 1980s. So in principle, we've got a reliable approach, a reliable excess incidence approach, but there's a lot of question about whether the background incidence trend is reliable, and it's important to recognize that that background trend is an extrapolation over 30 years, so even a small change in the slope of that line could really impact the excess incidence estimate. And it's difficult to figure out the background incidence. Here's a prostate cancer. These are prostate cancer trends before and after the introduction of PSA screening, that big peak coming after the rapid introduction of PSA screening in the late 1980s and early 1990s. But you can see that even before the introduction of screening, there was an increasing trend in prostate cancer incidence. That trend was due to increased use of surgical procedure for benign disease, but it's questionable whether that trend would have continued in the absence of screening, because medical management of benign disease became adopted right at the time that PSA screening took off. And so it's really hard to know, and it's likely that that increasing trend would not have increased. But again, without observation of that counterfactual incidence were often reduced to ultimately doing an extrapolation or even a guess. The last slide I'll show you, or the last study I'll show you, is one that is a population study, but that actually had a reasonable approximation potentially to a counterfactual. And this was a study of breast cancer incidence in Norway. And what happened in Norway was that breast cancer screening was introduced in different areas or counties at different times. And so here, the rows here are the different counties or areas, and the columns are years, and the dark blue squares, the dark green squares are the points at which screening was introduced in each area. And so you can see that screening was introduced at different times, and the areas that hadn't had screening introduced could potentially serve as a background or counterfactual for the areas in which to get a sense of what would have happened to breast cancer incidence in the absence of screening. This study is a cumulative excess incidence, but only after the first year of screening introduction. So that first year is omitted, recognizing that there's an excess even without overdiagnosis. The background incidence is imputed based on countries not implementing screening. But in this study, there's a question about timing, because you can see that for most of the countries that implemented screening, we don't have very long after the implementation to actually calculate incidence. And again, it's cumulative excess incidence, which we know is problematic in population, in a continued screen population situation. Now, I've been talking a lot about that we have to wait long enough until the maximum preclinical duration. But what is the maximum preclinical duration for any cancer that might be detected by screening? In the case of breast cancer, this question actually has not been addressed, but there are several studies of the mean preclinical duration. And here's a study that looked across the screening trials and inferred the distribution of the preclinical duration with a consensus mean of about 40 months. And I will just say that this is an example of a fairly robust literature, statistical literature, that develops methods to learn from incidents about underlying latency, not just in cancer, but also in HIV, for example. And there's a set of models for doing this kind of work. And I'll talk more about this idea in the next part of the talk, in which I'll talk about modeling for estimating overdiagnosis. Okay, so as with the excess incidence part of the talk, I'll just advance some principles about modeling studies, and then we'll look at a few. There were fewer modeling studies than excess incidence studies, so this will be shorter than the earlier part of the talk, keeping an eye on the time so that we have time for questions. So in the modeling approach, we're trying to get below the surface of the iceberg. We're using incidence before and after screening to learn about disease natural history. And here's prostate cancer. If we know how much screening is going on, we can judge, right, the height and duration of that peak relative to the pre-screening incidence, and perhaps learn something about the underlying disease natural history, particularly the latency period. An interaction of screening with the latency period or sojourn time is going to help us to learn about lead time. And then once we know lead time, we can compete that with the risk of other cause death to get an estimate of overdiagnosis. But what do we need to know what are the prerequisites for a useful model? Well, we actually need incidence with and without screening. The incidence without screening is not enough. We need the incidence also with screening, and we need to be able to compare the two. And so we have the same problem when we're in a population setting, that we might not have a good estimate of incidence without screening. You might not have that counterfactual. But in trials, again, we will have a control group, which hopefully can give us that information. So we need data on disease incidence with and without screening. We need information on screening patterns that produce the incidence. We can't just look at incidence. We need to know how much screening happened. In clinical trials, screening trials, we often have individual level data on screening and mode of diagnosis. In population studies, we typically have to reconstruct screening trends based on administrative or claims data. And the third criterion is that we need a model that we can identify or estimate from the data. And this might sound esoteric, but I'll try to give you some insight into what I mean from this in a very intuitive way. The first study I'm going to show you is one that was published with the U.S. Preventive Services Task Force update of their breast screening recommendations earlier this year. And in this study, the background incidence, it's a population study, and the background incidence was imputed based on an extrapolation using age period cohort modeling from the period prior to the introduction of screening. This was a population study and with a retrospective reconstruction of screening patterns. There are 6 different models in this study. And so the results here are, I think, the median and the range of overdiagnosis across the models as a proportion of all cases detected for different screening policies. And so one has to look across 6 models to know whether that underlying natural history is really estimable from the data. So I'll spend a couple of slides just talking about this problem. Can the model be learned from the data? So what do we mean when we're talking about learning about a model? I've drawn out the idea here in terms of disease states. So we have a healthy disease state, S0, we have a latent or preclinical disease state, SP, and we have a clinically diagnosed or symptomatic disease state, SC. And when we're learning about how disease progresses through these states. What's the risk of going into the preclinical state? What's the risk of progression to the clinical state? And ultimately, if we have a screening test, we may also very frequently want to also learn about the screening test sensitivity. And that body of literature in the statistical literature in cancer and HIV and other diseases with a latent period, most of the models are of this sort. But when we're thinking about overdiagnosis, we may be thinking about a more complex path of disease progression in the sense that we may have preclinical disease that stays preclinical and is never going to be diagnosed and contributes to overdiagnosis. In that case, we have a more complex disease progression path. And we're trying to learn from available data. We're trying to squeeze, I have a picture of orange here, squeeze information about what's going on beneath the surface. And when we have a complex path, there are often many different paths that might be consistent with the same data. And we might not be able to learn about that. And in the case of the previous study that I showed you of learning across clinical trials about latency and underlying natural history, where these studies use this more simple model of progressive disease, not allowing for what we might call a mixture of progressive preclinical cases and indolent preclinical cases. This slide is, the idea of the slide is to give you a sense of how difficult it sometimes is to learn about a complex underlying path of disease. What we did here, and what this shows, is a data set. It's really just survival times. We've censored them at 5 years. And what we've generated is several different mixtures of indolent and progressive disease. And if we analyze that data set, assuming only progressive disease, we will get the consensus mean of 40 months that was estimated from those screening trials. But there are many different ways to construct the data that will all give us the same estimate. And that's what this figure shows. This figure shows on the horizontal axis the percent of progressive cases that have a finite lead time that might be consistent, that are consistent with the same data. So the data are consistent with everyone that we've generated. We can show that you can generate a data set that's consistent with everyone having a finite lead time with a mean of coming from a mean of 40 months, but we can also generate the same data with 75%, that's the second blue arrow, 75% being finite, 25% being infinite, and a different mean among the finite lead times. So this is kind of an exercise that we did. It was published earlier this year to point out that we might not be able to learn about complex structure uniquely from a single data set. I'll show you in the next couple of slides a model that we've fit to population prostate cancer data to contrast with the excess incidence study of prostate cancer that I showed you earlier. And again, if we go back to these three criteria, what is our background incidence? We assume that incidence in the background of screening would have remained constant at 1986 levels. We're in a population setting, so we aggregate screening histories retrospectively, reconstructed from claims and survey data. And we don't allow, in this case, a branching of natural histories. All of our natural histories are progressive. However, we allow a lot of heterogeneity in those natural histories because in our model, we have PSA growth generated from a population-based trial, and we have a heterogeneity in PSA growth, and we allow progression to be heterogeneous depending on the PSA growth. So we have progressive disease only, but we have heterogeneity in progression. And this is, from our model, shows you the heterogeneity of latency periods from this population model. And if we split it into cases that would not be overdiagnosed, they would have been diagnosed in their lifetime in orange, and in blue are the cases that would have been overdiagnosed. So the model is a progressive model, but it does have a fair amount of heterogeneity in the underlying distribution. So we can have progressive models that have heterogeneity, and we can try to learn about non-progressive models. And this final slide that I have here before wrapping up is really some investigations that we've done to see whether those progressive models that were fit to those breast cancer screening trials can be extended to estimate also a non-progressive fraction. In other words, those results from those screening trials, could there be a non-progressive fraction that was previously undetected by those progressive models? And so I'm showing you results here from three trials, the HIP trial and the two Canadian trials. And the top panel shows the estimated risk of preclinical cancer. The middle panel shows the mean preclinical duration for progressive cases, and the lower panel shows the indolent fraction. Why are there four estimates in each panel? Because it is not possible to learn this mixture model without, it's not possible to learn this mixture model and in addition to learn about the sensitivity of the test. The data are not rich enough to provide information on both of those, and therefore we have to presume a fixed sensitivity and then estimate the model. And this is an example of how sometimes when you have a complex model, it needs to be, other assumptions need to be made or the model needs to be constrained in order to estimate the natural history and overdiagnosis. So to summarize the main points about models, about modeling studies, is I think that modeling studies are difficult to read and understand and know whether they're valid. If you're reading a modeling study, there are three things you need to ask. What was the assumption or data used for the background incidence? Do they have reliable estimates of screening frequencies? What constraints have been put on the model to be able to identify it from the data? And I would urge all modelers who are publishing studies to address these three, and it would be wonderful if this could be a standard for all modeling studies to answer these three questions. So in conclusion, I hope it's become clear that overdiagnosis is an unobservable quantity, and it's hard to estimate. Excess incidence is an empirical, simple idea. We would love it to work, but it only works in certain settings, and it doesn't always work in clinical trials. Modeling studies are complex. They have a history, but it is universally true that models make assumptions, and when we're trying to estimate a complex natural history and allowing a mixture of indolent and progressive cases, we may have to make strict assumptions in order to be able to extract information that is unique and valid from available data. So in terms of the take-home messages, I think there are four. The first one is to be informed. What is the overdiagnosis estimate exactly? What is the denominator? What is the measure? Is it cumulative? Is it annual? Buyer beware. Understand why overdiagnosis estimates may be suspect. Don't believe everything you read. Media reports, I think, can just not address this complexity. But if you are able to take a report and think about what lies behind the results, maybe you can arrive at a point of trust in the numbers. And the final thing I will say is avoid the echo chamber. This is a very polarized field. There are camps that subscribe to a certain method and a certain preconception about overdiagnosis, and I think it's very important to read across the lines, to recognize that there are different approaches. And ultimately, I'm hopeful that by being careful and thoughtful about both approaches, that we can try to generate a consensus in the field. So I'll end there. A lot more to think about than just fatal retractions, and I look forward to questions. Thank you.
Thank you, Dr. Etsununi. We have one question from a viewer. They want to know, how does the incidence of... Can you hear me? Oh, sorry. How does the incidence of overdiagnosis of heart disease leading to unnecessary stents compared to those for different cancers?
Okay, wow, that's a huge question. So I don't know nearly as much about heart disease as I know about cancer. I also can tell you that even for different cancers, we don't know exactly what the incidence of overdiagnosis is. And then I would ask, is the notion of overdiagnosis in heart disease the same as the notion of overdiagnosis in cancer? And different concepts of overdiagnosis in heart disease will generate different estimates. So I think that it's a big question, and I guess I don't really have a simple answer for it.
Thanks, Ruth. I think you're right that it is a big question. Maybe you could comment on whether from various types of studies there's been much evolution over time in our estimates in the cancer arena about what are these preclinical periods.
Okay, I think that if you're asking about the preclinical period, so then I'm thinking that you're asking about modeling studies. And I will say that I don't think that there has been a lot of evolution. I think that what happened in the cancer arena, and again, it's different for different cancers, but if we take breast cancer, for example, there was work in the kind of the statistical and biostatistical community, led by luminaries like Marvin Zelen, that took screening trial data and estimated these preclinical durations. And they never looked at overdiagnosis. At the time, overdiagnosis wasn't a topic. And so, as a consequence, those methods have not yet been evolved for for the overdiagnosis discussion, and that's what we're trying to do. So the work that I showed you at the end, where I showed you that we're trying to use that, we're trying to expand those models to account for an indolent fraction. That work is actually being done with a former collaborator of Marvin Zellin, and expanding the author of that trials paper that gave the 40-month consensus. We're working with her to try to expand those models and to learn about the limits of the data in estimating those complex models. But we're recognizing that there isn't going to be a unique answer, because depending on what we know about screening test sensitivity, for example, that's going to yield a different answer. So the short answer is it hasn't evolved a lot. I think in prostate cancer, in the Cancer Intervention and Surveillance Modeling Network group, which supported a lot of this work, we have been working in prostate to evolve and refine estimates of overdiagnosis. But that has only been maybe in the last decade, so it hasn't been over a long period of time.
Great. That's how Renelle has another question from listeners.
How do we estimate or calculate overdiagnosis in screening trials with no control groups or receiving other tests?
So you can do it if you have. I think you can do it if you have an adequate number of interval cases. In other words, in a screening trial where you're screening frequently and pretty much everyone in the screening arm is detected by screening, you can't do it, right? If you have a screening trial where you have less frequent screens, you have patients being diagnosed between screens, you may have and you have follow-up maybe after the end of the trial and are tracking diagnoses in that time, in the absence of screening, potentially the end of the trial, you may be able to extract a model of natural history. But in the case where you don't have very many interval cases are much more informative than screen-detected cases, because screen-detected cases, their latency period is essentially censored. And interval cases, you see when they're clinically detected, and so their latency period is not censored, and they're more informative. So you need both if you're not going to have a control group.
Ruth, I wanted to raise one more question. People often have questions about false positive tests. Can you comment, we only have a minute left, about what the difference is between overdiagnosis and false positive tests?
Well, they're completely different. A false positive test is the test is positive, but the biopsy is negative. An overdiagnosis, the test is positive and the biopsy is positive. The consequences of both are very different, right? An overdiagnosis is going to potentially lead you down a path of treatment. A false positive is not. So the costs and consequences are very different. An overdiagnosis is a real cancer, but cancer is heterogeneous, so it's more likely to be a slow-growing cancer.
Okay, we have one question. Maybe you can answer it in 30 seconds.
Sure.
Can we use the fraction of cancer cases that die from their disease to help build models that need to partition progressive from indolent disease?
Well, it's going to be it's going to be a biased approximation. So I think it's and that's a certain definition of progression, right? Because progression doesn't only mean a progressive cancer is not only one that will die, but a progressive cancer is one that will, impact the quality of life, that will have, consequences for treatment and morbidity. So I think it would be an inadequate approximation because, as a very nice commentary in the New England Journal a couple of years ago titled, "There's more to life than death." So it's not just about, progressive is not just about dying of cancer. It would be, I think, an underestimate.
Okay. Well, thank you, Dr. Etzioni, for all of the useful information, and thank you to everyone who participated in today's webinar. On the Medicine Mind the Gap website, which is prevention.nih.gov/mind-the-gap, you will find several resources for this talk, including the slides, references, and a link to complete an evaluation. Your feedback is very important to us as we plan future sessions. Thank you again for your time, and we hope you will join us next year in January when we kick off a new set of seminars for 2017. Stay tuned.